So welcome to our new series called Charging Forward Virtual Medical Symposium Series. We created this program because we want to give you the opportunity to hear the best information on vEDS from our professional advisory board and other leading medical experts. We are grateful to the Chu and Chan Foundation for making these webinars possible. Before we begin, if you have not visited our new website for the vEDS community, we hope that you check it out at thevedsmovement.org and find the resources available helpful. As you know, tonight's presentation is on pregnancy and women's health in vEDS. If you have questions during the presentation, please type them in the Q&A box, which you can see on your screen. We will leave time at the end to answer questions. I am very excited now to introduce our speaker tonight, Dr. Melissa Russo. Dr. Russo is a maternal-fetal medicine and clinical genetics specialist in the Division of Maternal-Fetal Medicine at Women and Infants Hospital in Rhode Island. She is board certified in obstetrics and gynecology, maternal-fetal medicine, and genetics. Her research interests include prenatal genetics and reproductive and pregnancy outcomes in women with connective tissue conditions such as vEDS, Marfan syndrome, and Loeys-Dietz syndrome. Now we are ready to start the webinar, and I will pass control over to Dr. Russo.
Okay. All righty. Give me 1 second.
There we go.
Right. Can everybody hear me and see the screen?
We can hear you and see the screen.
Okay, perfect. Well, I just want to say good evening, and today we're going to be talking about women's health issues, and I'm really excited about the vEDS movement and Katie leading it, and I think this is such a great initiative, and I'm happy to be a part of it. Okay, so what are we going to talk about? We're going to be talking about really what are women's health issues, just to define it, and then talk about gynecological and obstetric problems encountered by women with vascular EDS. We're also going to then discuss potential treatment options, not really to tell you what to do because we don't have a lot of data as to know what to do, but I want to give you guys the tools so that you can have discussions with your doctor if you are having issues with some gynecological problems or you're considering having a pregnancy. So what is women's health? It entails a course of obstetric and gynecological health, but it also entails mental health, emotional and spiritual health as a woman. Sexual health is, I think, a big part of what it is to be a woman. And really, what is women's health? You know, men and women are different by their sex, and how does being a woman and what that entails in terms of hormones and your body affect your overall health in general, and is there specific effects related to vEDS? Okay, so this is just a general review. We're not going to spend a lot of time on this, but I just wanted to go over vEDS, as you know, is a rare condition. It's about 1 in 50 to 1 in 200,000 individuals are affected. It's autosomal dominant, meaning that you have one gene in your 2 sets of genes for the collagen 3A1 gene that's affected. And when a person has vEDS, they have a 50% chance of passing this on to their offspring every time they have a pregnancy. There are changes in this gene that can be inherited and passed down from one generation to the next, or it can be a new mutation in a person where they're the only person in their family with this condition. And these genetic changes can be protein altering, where they actually change a glycine, particularly where the collagen is no longer able to be tightly wound, and that can affect things like blood vessels and other things where collagen is used in the connective tissues, versus null mutations are sort of seem to be more, less severe. Moving on to, when do we think about this diagnosis? Typically, it's going to be clinical findings that in the medical history or physical exam that start to make us think about this, and then we would do genetic testing. Traditionally, fibroblasts were used to look at the type 3 collagen, and now we have genetic testing available that can be done on a blood sample or on saliva. And there's lots of different gene changes that can occur in the collagen 3A1 gene. In terms of criteria, there are major criteria that are arterial aneurysm, dissection, and rupture, an intestinal rupture, a uterine rupture during pregnancy, or a family history of vascular EDS. And then you can also read about all of the minor criteria. So getting on to what we're going to be talking about tonight, here are some of the gynecological issues we're going to talk about. And just to be upfront and candid, a majority of what I'm going to be presenting is based on very, very small numbers, and we just don't have a lot of data to inform our care yet for these issues. There's still a lot of work to be done, and my goal, for my career is partnering with some of my colleagues, and I have 2 colleagues in particular at Brown that I'm partnering with that are gynecologists mainly, to do some of this research in the future to help us get some more answers. And as we go through these, I want you to also remember that, potentially women are having increased risk, or they feel like this is more common in this population, but just because it's more common doesn't mean that vEDS is causing this. And I think we have to do more research before we would really say that. Okay, so all the data that I have is really based off this one study that's in the literature. This was an anonymous online questionnaire that was funded by the Ehlers-Danlos National Foundation, and they recruited women ages 18 to 40, and they had 775 respondents. But you have to remember, this was all of the types of EDS, and women with vEDS encompassed only 4.8% and 37 women. So all the data I'm going to present is basically from this paper. So first, just talking about infertility. This is the ability to not achieve a pregnancy after trying to get pregnant for a year. Women with vEDS reported about a 30% chance, or it was a 30% rate of them having fertility issues. And this was seen to be similar in other EDS types. The causes of fertility that were listed, sometimes there was no explanation. Sometimes it was polycystic ovarian syndrome, where the ovary doesn't actually release an egg every cycle. Endometriosis was an issue, where tissue that's typically inside the uterus is found in other places and can cause pain, scarring, and infertility. Uterine fibroids, an abnormally shaped uterus, adhesions in the uterus or scar tissue, damaged fallopian tube, or an abnormal cervix. In women with vascular EDS, the most likely suspected causes were no explanation or polycystic ovarian syndrome in 33%, and then endometriosis and abnormal uterus was 22%, and uterine fibroids and adhesions in 11%. But again, if you look at the numbers, that's sort of in the highlighted column, it's very, very few responses. So I think we just need a lot more information. Moving on to menstrual problems. 83% of women with vascular EDS identified as having dysmenorrhea, which is where you have very painful periods. And in this table, you can see 27% had bleeding in between periods, and 35% had irregular periods. Comparing with all the EDS groups, women with vEDS had the highest rates of intramenstrual bleeding, which means bleeding between your periods, and heavy periods. So talking about heavy menstrual bleeding, the medical term for that is called menorrhagia, and greater than 50% of women had cycles at 26 to 32 days, and 46% had heavy periods for up to 6 days, and 53% had heavy periods for 7 or greater days, just with the vascular EDS women. So this is sort of a busy slide with some words that you guys may not know what they mean, but basically when we see somebody in the office that has heavy bleeding or bleeding in between periods, there's a bunch of reasons that this can happen. And the first box is really talking about structural reasons where someone can have heavier bleeding and instrumental bleeding, which includes like a polyp or adenomyosis, which is something where the wall of the uterus is somewhat thickened and abnormal. Leiomyomas is a fancy term for fibroids. And then, of course, on a differential, cancer is always there, but that's usually a rarer occurrence. And then talking about the non-structural causes, these can be if somebody has some other type of coagulopathy or a bleeding problem, problem with their ovaries or ovulation, a problem with the endometrial tissue, which is inside the uterus. Sometimes medications can cause bleeding problems, and then N is not yet classified. So how is this treated when women have heavy bleeding? This is not really specific to vEDS, but this is what a gynecologist is thinking about when they're thinking about how am I going to treat somebody with this heavy menstrual bleeding. So the first question is, are hormones contraindicated or not? And I put the question marks in there because I think we don't really know. Expert opinion and theory is that estrogens are not good for women that have any kind of vascular problems, but we just, again, don't have a lot of data to base this off of. And I think, we can wait for the question and answer session and I can talk about that more if people are interested, but I think estrogens are not recommended, but on a case-by-case basis, sometimes that might be, important for a short course, or, progesterones, if they're just in the uterus with the IUD device, which I show here. There's different names that are brands of that, the Mirena, Liletta, Skyla, or Clina. And then talking about sort of other medicines are listed in that table, which tranexamic acid is there, NSAIDs that entail, Motrin or Aleve, and then the Danazol is sort of reserved for more severe types of bleeding, and it's rarely, it's rarely, or it's not the first line of treatment. So, there's medical options, and then if those are exhausted, then there is potentially surgical options. Uterine artery embolization is listed there, but I don't think I would recommend that in somebody that has vEDS. Endometrial ablation is sort of this little machine they put in the uterus where they can sort of burn the tissue inside of the uterus to make that uterine lining stay very thin. That I'm also not really sure if that's the best option for somebody with vEDS. And hysterectomy is always there, but that is a major surgery, and then you have to recover from that. So, in terms of what is the best treatment options for women with vEDS, I don't think we have the answer yet to just put an algorithm out there, and it's something that needs to be talked about with your doctor on a case-by-case basis. So this was a slide where they just looked at in that paper rates of women having surgery, and the top things that women with vEDS were having surgery for was ovarian cysts, endometriosis and pain, and heavy periods. So talking about sexual health a little bit, I think this is an area where we have definitely a lot more questions than answers. The study looked at one problem that can be associated with sexual health, which is called dyspareunia, and that is where people have painful sex or intercourse, and there can be a lot of different causes for that. 80% of women with vascular EDS in the study identified with this problem. I have gotten questions in the past about people in the community who ask, is sex safe? Can I have an orgasm? And is that, someone potentially died having an orgasm? Is that something I should be worried about? And I think we really don't have any data yet. And, we don't even know necessarily what triggers arterial events in individuals with vEDS. And so I would say that sexual health, if you want to be sexually active, or masturbation is something that is something you want to do, I think that you should be able to do that, and I don't think you should be afraid of it, because I think we just don't really have answers, and I think to limit yourself and not have sex is not really a good option to put out there to women. We're going to talk about pregnancy in a little bit, but contraception or birth control is another area where we just don't have a lot of data, and it's mostly based on expert opinion. In general, again, we think avoiding estrogens is the best, and there's mixed opinions about IUDs. I think some experts believe this is not a good idea because one of the risks for all women with this is that you could get, when you put the device in, it's put in the office, when you get they do a speculum exam and then they put it through they sort of feed it through the cervix and then it open up the arms of it inside the uterus. And there's a risk of potentially poking a hole through the uterus when you insert this. In the general population, that risk is about 1 in 1,000, and we just don't know what the risk is in women with vEDS. But I think really I wouldn't put this entire type of contraception out until we really have evidence that it's bad, because I think it's a really good option for women and it can be used for things more than contraception. The progesterone IUDs are very helpful for women that have heavy periods sometimes. And then the last thing I wanted to say about this is, I think birth control is important, especially if you've been told that pregnancy could be a higher risk for you, because we're basically telling women, okay, don't get pregnant, but we don't know what you can use for birth control, so don't use anything. And then again, you're put in this position where you feel afraid to have sex. And I think that that's not really healthy either. I put on here this website, which I think is really, really great if you want to just get more information and you don't necessarily feel comfortable talking to a doctor at first and you want to just get more information. It's called bedsider.org, and it has all the information just in general about birth control methods, so you can look at them and then potentially work with your doctor to figure out if that's a good option for you. All right. So Urogynecology is another piece of gynecology where they mainly help women that have issues of pelvic organ prolapse, where either the bladder, the uterus, or the rectum sort of starts to come out and women feel a bulge potentially. There are surgeries that can fix this and potentially devices that can help with this. Urinary incontinence is another problem that people can have, sometimes in relation to the pelvic organ prolapse or sometimes separate. There is no data actually in women with vEDS on this, and I was trying to look. There is some data in the EDS population in general, but nothing really specific for vEDS. So now I'm going to switch gears and we're going to talk about pregnancy. So pregnancy is something that we potentially think there's a higher risk. This is a higher risk period for women with vascular EDS. Why do we think that? Because with the data that we have thus far, we think that the risk of a woman passing away during pregnancy is much higher than it is in the general population. But I think the question remains, is pregnancy actually, contributing to that cause of death, or is this something that was going to happen potentially regardless of whether a woman was pregnant or not? In terms of the specific risks that a doctor should really talk to you about in terms of the risks we think women have if they are going to have a pregnancy, is there's potentially a risk of arterial dissection and the mortality we already talked about. Obstetric risks is we think women have a higher risk of having preterm birth or a preterm rupture of membranes. And this actually is much more of a risk if the baby has the same condition, because their genetic material is making that sac that's surrounding the baby. There's the risk of uterine rupture, which is something that people can survive, but I think this can be a life-threatening thing for the mom or the baby. And then in case reports, hollow organ rupture has been talked about as well, like intestines, liver, or spleen. If you look at the graph on the right, this is out of Mitzi Murray and Peter Byers' paper, where they compared basically the graph on the left is looking at women who never had a baby versus women who were pregnant. And the Kaplan-Meier curves basically look at overall survival, and there was not a difference between women who had a pregnancy and did not. On the right, they looked at sort of other family members that were women in that family to see if there was a difference, and there was not. So, you know, I think the question really remains, is pregnancy putting women at higher risk? I think we don't know for sure, but we do know that, you know, there are potential risks that can occur during the pregnancy. So why is this? There's changes in the cardiovascular system during pregnancy, and there's also hormonal changes. So hemodynamics are basically that there's more blood pumping around the body, and the heart's working a little bit harder, the heart rate's a little bit higher, and all of this can put stress on the blood vessels. In terms of hormonal changes, we know that the estrogen and progesterone goes up all the way through delivery. And in studies of 2 women that died from dissections, they actually looked at different arteries in these pregnant women and found that there was changes that they thought was due to the high estrogen levels in the walls of the arteries. And again, we don't know, this is sort of a theory, and we don't have evidence, but this is why we are more concerned in pregnancy. So how have we been doing as providers? This table tells you, if you look, the vascular EDS women, 62.5% of them were told not to ever conceive because of their condition. And I think the most frightening thing to me is that if you look at the bar graph, is a lot of them were not then told of all the options that were available to them if they wanted to become parents. And I think this just shows that we need to do a better job as providers to give women the options, and we're going to talk about these a little bit later. So management of pregnancy in women with vascular EDS. So I found this graph on the left somewhere else, and it basically talks about a care team and your plan, and then planning for the extraordinary. And so I made up my own things to plan ahead, assemble your team, decide if you want to test your baby or not, and then talk about pregnancy. So preconception is before you have a baby or before you get pregnant. It's important to plan. And, you know, sometimes women are on angiotensin receptor blockers, and that can actually be harmful to the baby's kidneys. So we want women to be off that at least 6 weeks before they would consider getting pregnant. And we would get them onto a beta blocker. Those are relatively safe in pregnancy. Imaging studies, it's good to get imaging prior to pregnancy to try to avoid radiation exposure to the fetus if we were going to do a CT scan. We want to look at the blood vessels, and we also want to look at the spine, which we'll talk about in a little bit. Genetic counseling, I think, is important so that women understand, and men, that you have a 50% chance of passing this on to offspring, and there's genetic testing options available on the embryo, potentially before you put it back into the uterus, or you could do testing on a pregnancy in the first or second trimester with sampling of the placenta in the first trimester, which is a chorionic villus sampling, or an amniocentesis in the second trimester. And then, of course, talking to your provider about the risks in pregnancy that I talked about. And, you know, again, is there effects on potential long-term health, and is pregnancy something that you want to do? And then, you know, I think another part of this plan is, like we talked about, talking about contraception or birth control so that you can have sex without worrying about getting pregnant. So assemble your team. We want to have a multidisciplinary approach if you are going to have a pregnancy, which should include a high-risk obstetric physician, and that's what maternal-fetal medicine is, cardiologists, cardiovascular surgeons, anesthesiologists. The NICU are sort of the baby doctors, and nursing leaders and nurses from all the subspecialties are equally important because they're going to be the ones on the front lines taking care of you as well. The delivery, I think, is recommended for women, that they should be at a hospital with a cardiothoracic surgery available just in the case of an emergency. And then I think the key things are really education to everybody on the team, simulation and contingency plans. And on the right, I have a picture of a patient I had with Loeys-Dietz syndrome, actually, but we had different plans in place of what we were going to do in terms of planning the delivery, and then if something else happened, you know, where would she go and what would we do? So In terms of management during the pregnancy, we want to look at the vascular system in general. We recommend, again, the beta blocker during pregnancy, and metoprolol is the medicine that's preferred. And then in terms of assessing everything, we would say echocardiograms and potentially MRIs are something that is very safe in pregnancy, and working with the cardiologists and vascular surgeons to come up with the frequency that this should be looked at during the pregnancy. In terms of surveillance of the fetus, we want to do something called a level 2 ultrasound, and that is a very detailed anatomy scan where we look head to toe in the baby to make sure all the structures look okay. We know that prenatally we can see signs of vascular EDS in the baby, where we can potentially see clubbed feet. And then there is something that's called amniotic band syndrome, where basically the membranes are sort of like cellophane, and if there is a tiny tear or rupture, they could potentially wrap around an arm or a leg of the baby and cause limb abnormalities or potentially other problems. We don't know how common this is, but it has been thought to be that this is more common in women with vascular EDS or babies with vascular EDS. We'd also recommend growth ultrasounds every 4 weeks, and that's for women on the beta blockers because we think there's maybe a higher chance of the baby coming a little bit smaller with time, and so we just do that as a precautionary method or for precaution. In terms of anesthesia, there's really not a lot of data out there, and there's no clear recommendations. Case reports and case series have shown that spinal and epidurals have been successful in women with vEDS. And from Dr. Byer's biggest cohort, I think a lot of women did receive regional anesthesia and did just fine. But I'll tell you that some anesthesiologists think that vEDS is a contraindication to doing regional anesthesia. Potentially there's a higher risk of a postdural headache if there's a hole left in the dura or the sac that surrounds the nerves in the spine. And with dural ectasias, that's also something that, anesthesiologists debate of whether it's a good idea to do regional anesthesia because the medicine can sometimes pool in those little pockets that you see on this picture. And it really just, the medicine doesn't work as well. And so I think it's just working with your local anesthesiologist, making sure they're aware of your condition and working with them ahead of time to think about how you're going to achieve anesthesia for the delivery. And the other thing to talk about is we know women potentially have a higher risk of having bleeding at the delivery, and so we want to make sure that ahead of time we're ready for a blood transfusion if needed. In terms of delivery recommendations, we think that Cesarean is the recommended method for women with vEDS, and that is because of a few issues. We know that women, are at risk for this uterine rupture, and so we don't really want the uterus to contract, which is what it would need to do if you were going to have a vaginal delivery. And secondly, women that deliver vaginally have had really, really bad tears in the vagina and the cervix, which then is very, very hard to repair, and they can potentially have a lot of bleeding and have life-threatening risks from that. In terms of the cesarean, I think you should pay special attention to the tissues. Exactly what that means, I can't say, but I think just being very mindful. We don't have any specific special clamps or anything that we would use for women with vEDS. And case reports and case series have talked about using a prophylactic DDAVP, which sort of helps the blood clot a little bit, or tranexamic acid. I have talked to Dr. Shalhoub, who's also a specialist, and I think that's not something we really routinely recommend for other surgeries, so I don't think it's something we can routinely recommend for a cesarean delivery. And then in terms of the timing, I think we don't know the optimal time to do this, and we're weighing the risks of prematurity for the baby against having, a healthy delivery for the mom, and that can be anywhere from 34 to 37 weeks. In terms of postpartum recommendations, I think inpatient observation for at least 42 to 72 hours, which is typical for a C-section. Imaging prior to discharge, potentially, depending on how far away you are from the hospital, and then imaging, after the delivery. And I'm not going to talk a lot about this, but you know, there is data in mice in the Marfan model that potentially oxytocin, which is a hormone that sort of helps you go into labor and then continues to let milk let down, is potentially harmful in the mice. But I think we just don't have any evidence yet in humans, so I don't think we can say not to breast. The breastfeeding is bad in humans because we just don't have the data yet. Okay, and then I think the important thing to talk about was just the path to becoming a parent. I mean, if you want to be a parent, there's lots of different ways to achieve that. Pregnancy is one. You can do in vitro fertilization, potentially for testing the baby, or to put that embryo into a different person, to have them carry the pregnancy for you. And that would be a gestational carrier. Adoption is an option sometimes. And then some people choose just not to have kids. And I think that's a very valid choice as well when you have, you know, pets or plants as a parent. And I just wanted to end talking about positivity in pregnancy, because I know I talked about a lot of scary things that we think potentially could happen. But women can really have healthy pregnancies, and this is a baby of a healthy pregnancy of a woman that had vEDS. And I put a picture up here of Crystal Nichols, who she unfortunately passed away recently, and she was a very courageous and strong woman. And she gave this wonderful talk just because she delivered a baby, and she, you know, was told over and over again all the risks. And at some point she said to her doctors and became her own advocate and said, I need you to just be positive with me. I know there's risks, but I need you to embrace that this pregnancy is happening and I'm happy about it and it's going to be a good experience. And I think, you know, it shouldn't have to be on you guys to do that, but I would say do what Crystal did and really be your own advocate. And she was just such a wonderful person. So plan ahead, assemble your team, and get through, and you can get care throughout your pregnancy. These are sort of the main points in a pregnancy. And then in terms of women's health issues, I think we just have a lot more to go. And we're just at the cusp of realizing there may be issues in women's health that we have to explore to see how we can best help women. And remember that association is not causation. So we don't yet know if heavy bleeding is actually something caused by vEDS, and we just need to get some more information. In terms of hormones, I think it's something that could be considered on an individual basis, but we just don't know if it's safe. And really, we just have a lot of work left to do. And here's some of the work that we're doing. So I currently have generous funding from the Marfan Foundation, and I'm working on this project called ProGAD with some pilot places where we are collecting information on women during their pregnancies, and this is hopefully going to turn into a prospective study that's going to be bigger to get more information on pregnancy, contraception, and mental health issues in pregnancy. There's upcoming studies that I think will blast out, and I want you to keep an eye out for. There's one that hopefully we're going to have our IRB approval soon for this thing looking for attitudes towards motherhood in women with Marfan syndrome and related conditions, and that's going to be for women who have had a pregnancy, are currently pregnant, or are thinking about getting pregnant in the next year. And then hopefully we're going to get some studies together looking at contraception and also menstrual cycle disorders. And I also want to mention, and Katie's going to go on to talk about this, but the vEDS Collaborative has an ongoing study that she's going to tell you more about. Thank you very much. And my email is listed here, and everybody at the Marfan Foundation knows how to find me if you forget my email, but I'm always happy to try to help or get you hooked up with the right people so that you can get the care that you need. Thank you.
Thank you, Dr. Russo. We do have a question in the Q&A box. Before we get to your question, I'd like to take a few minutes to tell you about the vEDS Collaborative. So I'm going to go ahead and pull up the PowerPoint again. Okay, So the vEDS Collaborative is currently enrolling individuals with vEDS in a natural history study. This is the largest study in the United States for vEDS, and it's led by Dr. Shireen Shalhoub at the University of Washington. You can enroll in the study by emailing the vEDS Collaborative at vedskoll@uw.edu or by indicating you wish to enroll through the backpack registry. I'm getting a little bit of feedback. I'm just going to check and see if everybody is on mute real quick. Okay, it went away. Sorry, everybody. If you haven't heard about Backpack Health, oh, I forgot to do this. It's an app for your smartphone that has two functions that are very important. One is to compile the health records for you and your family members, which is safe and secure, comes in 6 languages, and has functionality that allows you to share certain information with others in your circle as you wish. Whether it is a school nurse at your child's school, with grandparents who are taking your kids on vacation, a new doctor, or EMTs in an emergency situation. The other function here is for research. Backpack Health is open to everyone with vEDS. Like I said, it's free and secure. After you consent into the registry, your information will be de-identified and aggregated with information from other people in the registry. This makes it possible in the future for researchers to answer questions that can impact your life, your children's lives, and future generations. Joining Backpack and the registry is free. To join, go to thevedsmovement.org and visit our healthcare management tool page. There's a lot more information on Backpack Health on our website, and our friends at Backpack are always available to help. You can also indicate you wish to join the vEDS Collaborative Natural History Study once you are enrolled. So with that, I'd like to stop and go to the Q&A box so we can answer your questions. So the first question that we have, and Melissa, I might share the screen back to you. In the graphs about deaths in pregnancy versus no pregnancy, were all causes of death looked at or just vascular? I'm going to go ahead and share this back with Dr. Russo so that she can pull up her screen.
Give me one sec. Hold on. Let me get back to that. I think it was here. Yes. So,
I cannot see your screen.
Oh, sorry. Hold on. Give me a sec. Let's see if we can do this. You see that?
Yes.
Okay. So here's the Kaplan-Meier. I mean, this is comparing women. So her question was vascular versus any kind of death, yes?
Yes, and the graphs about deaths in pregnancy versus no pregnancy, were all causes of death looked at or just vascular?
I think it's all causes of death. I can look back. But yes, I think it's all causes of death.
Okay. Okay, the next question. At the right time, I'd like to ask about our young woman who wants a tubal ligation. Her MD has discouraged her and said it's current to be unlikely to authorize. If one is getting a ligation, what is the safest way to have that procedure?
All right, here, let me pull up the question so I can see. All right, so for this question, can you hear me? Yes? Hello?
Yes, we can hear you.
Oh, sorry. Okay. I think, so to answer the first part, you know, they just, that they're discouraged and said insurance is unlikely to authorize, I would say that's not necessarily true. And I don't know if this person has themselves called the insurance company, or potentially you need to find someone else who would, you know, partner with you in that decision and then try to advocate for the insurance company to cover it, because, you know, the argument would be is that, you know, pregnancy could be potentially life-threatening. For the second part, the safest way to have this procedure, I think, so there's two ways that people do tubal ligations, or actually there's more than two. So there's two surgical ways. One is where you have an open procedure, meaning that they do an incision and then they go into the belly and then they can take out parts of the tubes. And the other way is where they make, 2 to 3 small incisions, and then, using a camera can do what we would call minimally invasive or laparoscopic surgery. And then there's different ways to, tie or burn the tubes. And then the third thing that has been done, but I think has been stopped because there's concerns about safety risks, is an office procedure where they would potentially put these coils into the tubes, and then that would make the tubes scar down over time. And in terms of the safest procedure, I have to say that I don't know. And, I think this is something where I could potentially get back to them on an individual basis about this. Just in my reading for laparoscopic surgery versus open surgery, some people recommend that you should do open surgery and not laparoscopic surgery because of the higher risk of bleeding potentially. But I think I would defer to, a surgical, like a vascular, or one of our vascular surgery experts, to talk to them about that as well.
Okay.
Sorry that I don't have a better answer for that.
There's a lot of research to do.
Yes, I think the other things to think about with that, just to say that like a tubal ligation is, we think of as a very permanent method for sterilization. There's two options for sort of reversible long-term contraception, which work as well, if not better, than tubal ligation, which is the IUDs and the progesterone implants that can be put into the arm. And, again, we don't have a lot of information about any of these things, but that's something else to think about, which is not a surgery.
Okay. That person had a follow-up question about the ligation, if a vascular surgeon should be on hand.
I think that they don't necessarily have to be in the operating room, but I think it would be good to have, plans available in case there was an issue with bleeding or an issue during the procedure.
Okay. So the next question, as a teenager pre-vEDS diagnosis, I suffered from a vaginal tear after intercourse, so I'm afraid of it happening again. Do you see this as a problem with other people with connective tissue disorders without pregnancy or trauma?
I have, it's not very common, but I have actually heard of cases where that happens. I have heard of a case of someone with a connective tissue disorder who sort of tore during a speculum exam as well. And I think we do need to get more information. In the vagina, there is definitely collagen and connective tissue. And so I think that's something that potentially could be related, but I don't think we know.
Okay. Next question. Is there any research being done regarding menopause and vEDS? Estrogen is out due to history of DVTs and PE, but is progesterone okay? And how will menopause change our bone density?
Good question. And yes, I didn't have menopause in there. I should have. That is definitely an issue in gynecology. I think we don't know the answer. I would think if we get more information on women in general with, so progestin can also be something that causes a higher risk of clots, but maybe in a microdose it could potentially be okay. I mean, I think we don't know again. I mean, I hate to hedge and say something because I don't really know. I mean, we don't have information, but I think if we get more information about hormones and, you know, people's experience on hormones, that could be a first step to knowing more about the safety. And then in terms of menopause and bone density, so estrogen is important to keep bone density up. And all women go through menopause at some point. So menopause can affect your bone density because you're no longer making, you know, estrogen and progesterone levels. But I think that's something that there are other potential treatments for osteoporosis or osteopenia, but I do think a bone density is really, really important for all women, especially women with vEDS where they have potentially seen osteopenia and osteoporosis in younger people with vEDS.
Thank you. As far as egg retrieval, is that an invasive procedure for someone with vEDS?
Yes, is the short answer. So I didn't go into this, but you know, typically if somebody is going to do in vitro and they want to use, or they want to have a baby and they want to use their own genetic material, typically the fertility specialists will give you medicines to sort of first ramp up your eggs, which is hormone levels to sort of make, so you make more eggs, so when they go in to sample and take the eggs, they get more of a chance of getting a lot of eggs. There are people that can do natural cycles, or they can give medicines to sort of block the estrogen a little bit to lessen those hormones. And then in terms of your question with the actual, how do you get them? It's an outpatient procedure where they do have to sample. They do it under, I think, under ultrasound guidance. And they have, it is invasive in that they have to go in to take out the eggs. But it's not, sorry, it's not a surgery per se, but they have to use a larger needle to go in into the ovary to get the eggs. And is that safe? I don't know.
Okay.
I think the other option though is that you can, if you're this is a very personal choice, but you can have a baby but get an egg donor, where then you would not have to go through that process.
Got it. Next question. What is the percentage of normal women that experience infertility in comparison to the approximately 33% of people with vEDS shown in the study?
I think it's about like 20 to 30% of women. So yes, it's potentially not different from the general population. And so this is one of the things where I think about, okay, is this just in general that you have infertility, or is it really related to the vEDS? And I think we can't really assume that vEDS has a higher risk of infertility at this point.
Thank you. All right, next question. I was diagnosed with vEDS and I had my tubes removed in 2013 and became pregnant this year. Could vEDS be related in any way?
So that is what we were, so the tubal ligation is not 100% effective either, and that does happen. I don't necessarily think vEDS is related. I think that that's just a risk of the procedure, that you still can get pregnant. But it's a very, very, very rare thing that happens.
Okay. Next question. I understand there is not a lot of research surrounding pregnancy and vEDS. However, is there anything out there regarding women who have vEDS and had multiple pregnancies, either pregnancies before they were diagnosed or pregnancies after their diagnosis?
I'm not sure of the question. I think the question this person's asking is, if they've had multiple pregnancies, do we know if that affects their long-term health? I know if this person is still on the thing and you want to clarify, I don't think we know. I think if you tolerated the pregnancies fine and you went through them, I don't think that should have any effect. We don't know of any effects on your long-term health.
Okay. If there's a follow-up question after that, feel free to email me at kwright@thevedsmovement.org, and I will try to get that question answered for you. Next question. Let's see what we got here. On the list of medical treatments for heavy bleeding, the benefits of tranexamic acid.
Yep. There you go.
Can you explain why?
Oh, yes. So it's just saying that there's no other benefits to it. It's not, I mean, I think the biggest thing we worry about, which I don't think is on there with tranexamic acid, we're using that a lot more in pregnancy in general. Or sorry, I know about it a lot because we use it in pregnancy in general. It basically helps the body clot. And I think there's no other benefits to using this medicine, like that table. If you want me to go back to it.
Yes, I can pass you the remote again.
Yeah, here. Okay, wait, I gotta get rid of the questions. Here we go. Okay, so can you see my little pointer? Yeah. So here it's talking about, anyways, it's talking about in that second column, specific benefits versus adverse benefits, which I think is sort of funny. But it's just saying that, you know, what are the benefits to this medicine if you're going to treat somebody for heavy menstrual bleeding with this? There's not really any other benefits besides it helping with the bleeding. And the side effects, I think, include nausea and diarrhea like listed here. But then I think the other concern is, you know, we avoid this medicine in women where we think they have a really high risk of a clot. And I think we just don't know if individuals with vEDS are at higher risk for blood clots in general. But I think it's, you know, it's also called, so this tranexamic acid is also called Listida. And I think if somebody's having, you know, heavy periods, I think it's probably a good thing on the list to try.
Thank you. So it's that the specific benefit none means there's no additional benefit other than the heavy menstrual bleeding. Got it.
I think so. Yeah. Besides treating the heavy menstrual bleeding. Got it. Because if you look, for example, with NSAIDs, which is like, you know, Motrin, Aleve, those kinds of medicines, it also helps with the pain and it helps with headaches, if that makes sense. Yes, I think that makes sense. Okay, so we're at 5 of, so I'm going to go ahead and pause the Q&A. Any questions that we did not get to, we will get back to you on. So I want to thank Dr. Russo for your time tonight and thank all of you for participating. Additional webinars specific to vEDS are being planned, so please watch your email for upcoming dates and topics. And if you are looking for more ways to get involved, we are establishing Team vEDS at all of our walks for victory, and we're looking for members of the community to lead the teams.
You can visit marfan.org/walk for more information about our walks, and be sure to name your team vEDS, or let us know you're walking for vEDS in the description. We also have several regional symposiums coming up, as well as 3 upcoming camps. You can learn more and register for these at thevedsmovement.org. And remember, if you have a question, you can always contact our Help and Resource Center. This is the contact information for Jan Lynch, who is our wonderful nurse who heads up the Help Center, and she's just amazing. So again, thank you, Dr. Russo. Thank you, everybody, for joining tonight, and have a great night.
Thank you all.